Good morning, and so I'm very excited to be here. So at the risk of insulting y'all's intelligence, I'm going to tell you a little bit about the genetics to get us started. Humans have 22 pairs of autosomes and 2 pairs of sex chromosomes. And so, of course, if you're Marge Simpson, you've got 46 chromosomes and 2 X's. If you're Homer, you've got 46 XY. This matters because we get 1 copy of each chromosome from our mom, 1 from mom and 1 from dad. So Bart here gets 1 chromosome from Marge and 1 from Homer, and this is true for every chromosome every chromosome pair we have. And it's true for the sex chromosomes, of course, and it's true for our favorite chromosome 15. And it matters. So for most of the chromosomes, most of the autosomes, it doesn't matter which copy you've inherited from mom and which one you inherit from dad because they're both ostensibly the same. But for chromosome 15, that's not quite true because chromosome 15, Q11 to Q13, so not the whole chromosome, but a region of the chromosome is regulated by a process called genomic imprinting. And this is a phenomenon in which a gene is expressed exclusively from 1 parental allele. So how this looks for our particular region is that it's all set up by a differentially methylated domain here at SNRF-SNRP-N. It's unmethylated on dad's copy, it's methylated on mom's copy. And the region, this differentially methylated region, is called the Prader-Willi syndrome imprinting center. And so that's kind of the control module. And so that's what the white circles mean, is the methylation imprint. This methylation imprint is actually set up by another piece of the imprinting center called the Angelman syndrome IC. And for you aficionados, the point of the ASIC is it establishes the methylation imprint on the maternal allele in oocytes. So its job is in eggs to make sure that there's methylation, and that sets up the difference really between the paternal and the maternal alleles. The paternal allele is expressed for most of these genes, and so the blue genes are expressed exclusively from dad's copy. There's the upstream genes, MKRN, MAGEL2, and nectin, and then SNRF-SNRP-N makes a protein coding product and then makes this long non-coding RNA that is sometimes called the UBE3A antisense transcript, and that antisense transcript silences dad's copy of UBE3A. And that means that since dad's copy is silenced, the only source of UBE3A is from mom's copy. So this region is flanked by repetitive elements. We've given them a shorthand of breakpoint 1, breakpoint 2, and breakpoint 3 because they're common breakpoints due to these repetitive elements. They misalign during meiosis, and the deletion of either the maternal or the paternal allele can occur. These breakpoints also mediate duplications for Dup15q syndrome. And so when you're missing mom's copy of UBE3A, you have Angelman syndrome. If you have extra copies of this region, again mediated by these repeat elements, you would end up with the Dup15q syndrome. So to give you a quick rundown of Angelman syndrome genetics, which you probably don't need, but just to make sure we're all on the same page, Angelman syndrome can occur by a couple of different genetic etiologies. First of all, there are large deletions, and to orient you to these chromosome maps that were drawn by my talented postdoc Noel somewhere around here. The UBE3A is silenced on dad's copy, so dad's copy is blue, and that's what the X means. The little arrow means UBE3A is expressed from mom's copy. So in the typical case, you have a silent copy of UBE3A and an expressed copy. Large deletions occur such that the region encompassing UBE3A is deleted. 10 to 15% of individuals with Angelman syndrome have mutations in the UBE3A gene, so the maternal copy is inactive but present. Uniparental disomy is another case, another cause of Angelman syndrome, and this means that kids have inherited 2 chromosomes 15 from their father. And since they're both silenced, there's no UBE3A. And then the last class is imprinting defect. And so in this case, kids have inherited one copy from mom and one copy from dad, but the copy inherited from mom behaves as if it were inherited from dad. And so there's no expression of UBE3A from that. So in all of these cases, there's no UBE3A, and that's what causes Angelman syndrome. I do want to remind you that some of the deletions that cause Angelman syndrome include other genes as well. The genomic locus of UBE3A spans a distance of about 100,000 base pairs. And the deletions, usually there's deletions mediated by either breakpoint 2 and breakpoint 3 or breakpoint 1 and breakpoint 3. Those are the most common. And they're either 5 million base pairs or roughly 6 million base pairs. And within those larger deletions, there are other genes such as the GABA receptor genes, GABA or beta 3, alpha 5, and gamma 3, I can't ever remember which one's which. And then there's also, so the gray genes in this are expressed from both parental alleles, but they too may contribute to severity of syndromes. And this becomes even more important for the duplication syndrome. So the duplication syndrome is also interesting genetically because there's a couple of different varieties of it. So up at the top, you can see these maps of the ones I've told you about: normal Angelman syndrome, typical Angelman syndrome, and then Prader-Willi syndrome in the case that dad's copy is deleted. And for the Dup15q syndrome, you can have this disorder due to a maternal interstitial duplication, which means there are two copies of the whole imprinted region in tandem, and those copies are in tandem on mom's chromosome, so they're maternal copies. There's maternal interstitial triplications, so there's 2 extra copies instead of just 1 extra copy. And then there's isodicentric chromosome 15, or IDIC 15, and this is the most common form of Dup15q syndrome. And in this case, there are 2 extra copies of the whole imprinted region, the maternal copies, and those are on an extra isodicentric chromosome. Dicentric means that there's 2 centromeres, and they're fused tail to tail, okay, and that's their orientation. So if I drew this in a more scientific way, such as this nice figure from the gene reviews that many of you out here contributed to, along with Brenda Finucane. The interstitial duplications are shown in the middle here, where you can see the 2 copies in tandem. The red bits are the same, so here's a 1.1.2 to 1.3.1 in this case, 1.3.3, sorry. And so they'll be duplicated in there. This is, 1.3.1, and they're duplicated here in tandem in the interstitial case, and then in the case of the isodicentric, she calls it a triplication here because there's actually 3 copies in total. They're fused end to end on this extra isodicentric chromosome. In case you are wondering, the short arm, the P arm of chromosome 15, is not terribly useful, and so it's hanging out there, and we don't think about it very much. So the duplication seen in Dup15q syndrome can be mediated by the exact same breakpoints as deletions in Angelman syndrome. And I believe some of the more common ones involve breakpoint 3 as well as breakpoints 4 and 5, which are further down here. And remember that in the case of the IDICs, the kids with IDIC 15, they have 2 extra copies of a lot of different genes. And I again want to point out that there's extra copies of a lot of different genes. So it's not just UBE3A, there's the GABA receptor cluster. And I think it might be useful to pay attention to HERK2, which is another ubiquitin ligase in the region, as well as some of the other genes. So we're all here together today because UBE3A is at the root of both disorders. And so folks interested in Angelman syndrome and folks interested in Dup15q syndrome are both need to think about UBE3A. UBE3A is a gene. It encodes a protein called UBE3A for us idiots and E6AP for the aficionados like Martin. And so I'm happy to hear about the protein this time. And the protein is a ubiquitin ligase. It adds ubiquitin molecules to other proteins, and it's thought to target proteins for degradation by the ubiquitin proteasome pathway. And in fact, Martin's group and others have shown that it does that. There are 3 known protein isoforms that may or may not be discussed a little bit today. And again, I want to point out that there may be other genes that are critically important, especially for the Dup15q syndrome, and I want to point out the GABA receptor genes, which you'll hear a little bit about too. So with that, I'll turn it over to Ron.
Okay, so we're each going to try to give you a 10 to 15 minute clinical overview of each of the syndromes, and you'll be hearing more about what we'll be talking about today in detail over the next 2 days. Here you are. Lower.
Stormy needs it high.
Okay, there you go.
Perfect. Great. So I was actually going to talk about molecular targets of UBE3A, but instead I will talk about clinical Angelman syndrome. So let's see, where am I? Okay, great. So Angelman syndrome is it's basically a brain disorder. You know, the UBE3A is expressed abnormally in the nervous system mainly. So the manifestations you see clinically are typically brain manifestations. So epilepsy is super common, sleep disturbance is very common, developmental delays, movement disorder, anxiety. The one that's really not is GI dysfunction, but it's probably due to the neurological input to the gut, so it's kind of a brain disorder. And then we also see a lot of issues with eye movements and also with orthopedics, and that's due to low tone. Am I getting like a feedback thing? That's due to low tone, and so there's low tone in the eye muscles, there's low tone in the other muscles, and so you get orthopedic ophthalmologic issues. So seizures is one of the main concerns medically for kids with Angelman syndrome, and typically seizures start around 2 to 3 years of age for those that are going to have them, and about 80 to 90% of kids will have seizures in Angelman syndrome. They can start earlier, they can start later, but that's kind of the hot spot. That's the most common time for seizures to start. And what we see is that they can be really difficult to control early on, so that early childhood period is the really hard part. And then around puberty, we often see seizures kind of get better, kind of quiet down on their own. And then once puberty kind of passes, about 1/3 of people will kind of continue to have seizures or have the seizures return, whereas about 2/3 will stay seizure-free. And this was a slide from a study that Anna Larson did with our group. And looking at it, this kind of shows what we see when we're talking about where the age of seizures are most severe. 0 to 5, 6 to 10, and as time goes on, the seizures get less and less. And really the ones after 15, I think, are probably not so much seizures. I'll talk about that in a little bit. And definitely the 31 plus, that's probably not 20%, and I'll kind of explain why that is later. But basically, the seizures are really the biggest thing in childhood, and that's usually the most troubling issue, and it's more of an early syndrome kind of phenomenon. In the diagnostic criteria from 2005, it was listed as 20 to 80%. It was in that category. That there's the ones that you see 100%, and there's the 20 to 80, but really it's more like 80. It's in the high end of that. This study that we did we did it late in 07, but published it in 09. We had an 86% response. 86% people had seizures in the survey that we did. That's probably overestimated because it's a seizure survey, so there's going to be a little bit of bias, but 80% is probably about right. The epilepsy in Angelman syndrome is a generalized epilepsy. So even if you have focal seizures, since it's generalized, if you use medicines that really only treat focal seizures, you can worsen it. So the main seizure types are generalized tonic-clonic, which is the one we all think about. You kind of fall back, everything shakes, eyes roll back. They call them grand mals in the past. Atonic seizures, which is atonic meaning no tone, so you lose your tone, you either have head drop or you have a full body drop. Myoclonic, so someone's going to fall asleep during this, I know, and when you do, your neck twitches back, so that's kind of a little myoclonic jerk, but we all have those are normal. If you have really big ones that go on and on with an abnormal EEG in the background, that's a myoclonic seizure. Atypical absence are the staring spells. And then about 30% will have focal seizures, so seizures coming from one part of the brain. You might have just kind of face and arm shaking or just some kind of head and eye deviation to one side. But even though they're focal seizures, it's still a generalized epilepsy, and we still have to treat with generalized epilepsy kind of medicines. This was basically just showing that the different subtypes that Stormy had mentioned have different seizure rates and deletions. It's probably about 90% in UBE3A mutations, and UPD it's 70-75%. And imprinting center, it's about 50%, but that may even be lower. That was what we got in the survey, and there's so few that it might have been just the ones that had it. From the ones we've seen in clinic, it seems probably like it's lower than 50%. And those are the kids that will actually, on occasion, have normal EEGs. It's very rare to have a normal EEG with Angelman syndrome. You can have one that's non-epileptic and not see the spikes and the sharp waves that kind of tell you that there's a predisposition to seizures, but there's other kind of abnormal features on EEG, and the imprinting center kids just are so mild overall in their phenotype that you might even see normal EEG. So the treatments for seizures, so this was the survey we did back in 2007, and it shows that valproic acid or Depakote was the most commonly used, followed by clonazepam or Klonopin, and that was really the way of when Angelman was first being kind of diagnosed and treated and understood, and that was because back in the 80s those were really the only two medicines that worked. There may be Zerontin, maybe some others, but as new medicines came out in the 90s. And started to get used more, we really see that other medicines work just as well. And those numbers are a little bit inflated. Those were the kind of experience that we had, but a lot of those kids when we started the medicines were already on something, so could be additive, but just kind of relative to each other. They all seem to have pretty good effectiveness. These are the kind of most commonly used ones: valproic acid, levetiracetam, which is Keppra, lamotrigine, which is Lamictal, and clobazam, which is Onfi in the US, it's Frisium in Canada. And the LJT is the low glycemic index treatment, which is a diet that we use that's really effective in Angelman. And so what we see is that the newer medicines are basically as effective as the older ones. But what we've seen, which we just actually put a paper out, with valproic acid, we had a 72% adverse effect rate, and the way we kind of figured that out was we'd stop the medicine and things would get better. It's not really known why, because that's a good seizure medicine, it works, it doesn't do that to other kids, but with Angelman syndrome, we wonder if there's a mitochondrial component. That's something that's not really known. That's something that we need to figure out better. But Depakote's famous for making kids with mitochondrial issues worse, and so that always made me wonder that that's what's going on. Recently, there was a paper looking at coenzyme Q in mice helping, so there might be something to this whole mitochondrial piece. Because the mitochondrial issues also have lots of myoclonus, so that's really common in Angelman syndrome as well. So, but we've seen kids as old as 14 who never walked start walking when we took them off Depakote. So it can really affect motor skills. That's the big thing. Kids can stop walking. They can really lose their fine motor skills. Their tremor can worsen. So those are kind of our favorite medicines. There's others, but those are the ones most commonly used. We also use dietary therapy pretty commonly in Angelman syndrome. We did a trial. Which is the next slide. We did a trial of 6 children, which was kind of cool. It was the first ever prospective trial for low glycemic ever, and it's kind of cool that it was done in kids with Angelman. But 4 out of the 6 had a greater than 90% seizure reduction. 1 had a 50 to 90, and then 1 had a less than 50, but then later on actually did better. And so since then we've put 23 plus kids on it, and this is kind of interesting what we've seen as we've put more and more kids on it. So those with daily seizures, they all got better, and with 1 being seizure free except for illness. Those that had weekly, they all improved, but 1 seizure free except for illness. So there's kind of a pattern forming. Those that had seizures only when they were sick still had seizures only when they were sick. So the one thing that low glycemic doesn't do well is treat seizures when people are sick. When they get fevers, they dehydrate. The diet doesn't quite do what it's supposed to do. So a lot of times what we'll do is either kids will be on diet and 1 medicine, which will then help keep them seizure free, or when they get sick, we'll just give them some Valium to kind of get them through and really to kind of give them extra seizure protection while they're sick. So there are options. But the 2 things that the diet really it's great for seizures in general, but for when kids are sick or when they have non-convulsive status, which I'll talk about next. And basically, just to kind of go back, the low glycemic index. So the ketogenic diet is 100 years old, and it's this high-fat, almost no-carb diet, and it basically tricks the brain into thinking that you're starving. They figured out hundreds and hundreds of years ago that if you starved people, they would stop seizing. And the American Academy of Pediatrics does not recommend starving children. So they came up with this diet where, when you starve, you burn the fat you have on your body. So the diet it mimics that. You give them tons of fat and they burn that. And we don't know exactly what it is, whether it's the fat or the metabolites or the pH, but when you give kids high-fat diets, they tend to seize less. The brain just is happier when it's using fat instead of sugar. And so the general response rate for low glycemic is really good. It's better than most medicines. It's about 1/3 or 90 to 100% seizure-free, 1/3 kind of 50 to 90%. So the numbers in general are really good, but the numbers in Angelman seem to be better, and we're not quite sure why. The other thing that we noticed that I didn't put on the slide is that typical grams per day are 40 to 60 grams of carbohydrates, of low glycemic carbohydrates. So basically carbohydrates that don't raise your blood sugar that much. It's whole grains and not like 40 grams of ice cream, that'll shoot your blood sugar up. But we've seen kids that we put on the diet and then kind of backed off, and they still maintain the same seizure control on 60 to 80 or 80 to 100, and that's not typical through the epilepsy population. It's just as Angelman. So there seems like there's something about this dietary therapy that really helps. what we also see is we've seen better attention, better communication. We haven't proven that through measures, but you just see it. You see it in clinic. It's obvious. The parents see it. But what we don't know is whether that's the diet itself or just better seizure control, and that's one thing that we want to try to figure out at some point. And I mentioned non-convulsive status. This is something that's really more common in Angelman syndrome than other genetic disorders. And basically what happens is your EEG goes from looking okay to looking like, I don't have an okay EEG, but that's not okay. That's just constant spikes. It's just, and kids will kind of be doing their thing. They'll be playing and eating and doing whatever they do, but their EEG just does this, and they just spike all the time. And what happens is they just regress, and they regress quickly. So their balance is off. They're not walking as well. They're not making good eye contact. They're just not there. And so if that ever happens in kids with Angelman syndrome, it could be other things, but you have to always think of non-convulsive status first, because that's the most concerning, and it's really treatable. In a lot of kids that with with idiopathic autism or other genetic disorders, they come in, they have this non-convulsive status, they get admitted, they get a bunch of drugs. For kids with Angelman, we just give them Valium, and we see them in the office. They say, "Oh, that's non-convulsive status." We give them Valium, we send them home, and in almost every case it works. We've had a couple of kids that have been kind of benzo refractory. It's rare, but just a couple. In those cases, we've had to use steroids or some other things. But that's the main thing to remember. In Angelman, it's not a regressive disorder. It's not a degenerative disorder. So if things are going backwards, there's a reason. And so we always worry about non-convulsive status. It could be bad sleep, it could be behavioral, it could be other things, but you always have to think, is this non-convulsive status? So kids that we know that have had it once, when they happen again, we don't even bother with the EEG. We just say, yeah, it's the same thing, and we just start the Valium. Let's see. That's what we're just saying, the treatment. So we have, and for some reason, we just, it's, in general, people use benzos for this, but for some reason, diazepam or Valium just works better than the others. I can't explain why. I don't know why. That's what we see. So sleep problems. So next to, just from a medical standpoint, not developmental stuff, for just medically, the next biggest thing is usually sleep. That's what parents complain about. So sleep disorders in Angelman syndrome is higher than the overall autism population or developmental delay population in general. They're just notoriously bad sleepers. So in the diagnostic criteria, again, it was in the Stanley seizure, it was 20 to 80%. Caregiver reports have ranged from 40 to 80%, and it's probably somewhere in that neighborhood, maybe 60-ish%, somewhere in that neighborhood. There's many reasons. So kind of on a molecular level, going back to Stormy's talk, the GABA transmission has always been kind of thought to be the big thing in sleep. We know GABA helps to mediate sleep. When you give benzos, kids sleep better, that kind of thing. But now there's also some evidence that UBE3A can directly kind of act on the sleep cycle. So there's really kind of a complex interaction with the genes. But beyond that, if you're having more seizures, you're not going to sleep well. If you're on a seizure medicine that doesn't agree with you, you're not going to sleep well. And a big thing is GI symptoms. So I'll get to that too, but GI is common in Angelman syndrome, and the constipation, reflux, and if you're, when you lay down, your reflux will get worse, everything kind of comes up. So if kids wake up screaming and yelling, they're probably not just awake and having a bad sleep night, they're probably in pain. So it's tough, they can't tell you that, but if you kind of listen to them and kind of get what they're saying when they wake up screaming, they're saying, my belly hurts, basically. So, and anxiety can keep kids awake and keep adults awake and keep everybody awake. And then over the lifetime, sleep can be bad all the time, but it's compared to infancy and compared to childhood, it's better. Most people sleep better as adults, even though they don't sleep great. And then for medicines, there's not really much known. There's been a couple papers on melatonin, anecdotally. Trazodone, benzodiazepines, gabapentin, or Neurontin, clonidine. Those are some of the ones that are pretty safe and easy. I'll go a little faster. As I mentioned, GI symptoms are common. I won't get into too much detail. Constipation, 86%, reflux, 44%. And so just super common. Again, it's probably the neuronal input to the gut. It just doesn't move as fast. When stuff's not moving fast, water gets sucked out, and then you get constipated, then that backs up, you get reflux. So what we see with the one kind of the little interesting piece is that, I don't have it anywhere. Nope. But anyway, so what we saw was that constipation was consistent throughout throughout the subtypes, and that's probably more functional. It's not drinking enough water, it's eating the wrong foods, that kind of thing. But the upper GI symptoms, reflux, eosinophilic esophagitis, all that kind of stuff, was really almost exclusively in kids with deletions or UPD. We didn't really see it in kids with mutations or imprinting center defects. So as far as and then that's probably more just due to tone. The kids with deletions and UPD tend to have lower tone. And then I mentioned the seizures. We had that 20% were the worst at 31 plus. What we think happens in, well, not think, but what we see in older folks is that starting at puberty, anywhere from 10 on, we see these, the onset of myoclonus. So kind of, again, like you're falling asleep, you have that twitch, or you start to fall asleep, you dream you're falling off the cliff and you twitch awake. So that's myoclonus. But people with Angelman, almost all of them have a little bit. We see as they get to be teenagers and adults, they get more kind of twitchy. And you can kind of tell if you hold their hand, you still feel the twitching. It's not like a tremor where you hold it and it stops. So you get that twitching, and in some people that's all it is. It's just in the hands. It doesn't really bother them. But in some, it really spreads to the whole body, and it can be really severe. In the teens, they can last minutes, but in a certain group of people over 20, it can last hours, 4 hours, 6 hours. And we've hooked some of these folks up to EEGs, and there's no epileptic correlate. It's not a seizure. It's not epileptic, but it's a huge quality of life issue. So it's not dangerous, but it's really, really annoying. And so we try to treat it just for symptomatic, just to make people happier. But it's an issue, and this is kind of in the teens. You can see teens, 20s, 30s. We have a newer chart that actually shows a more stepwise increment. So we haven't seen anyone 50 or 60. We're not quite sure how it goes into those ages, but it tends to get worse over time. And so the question is this kind of related to some sort of mitochondrial piece? Is it is there a mild degeneration over time? It's hard to know. But the 40-year-olds that we've seen that have had a decent amount of myoclonus are also walking on their own and doing their thing, and so they look great otherwise. So it didn't seem degenerative. I don't think it is. I think it's probably more part of the movement disorder. You have tremor, you have ataxia. I think you also have myoclonus. I think it's just more of a movement disorder than a degenerative type of thing. But it tends to worsen with age. We use basically the same medicines to treat myoclonic seizures, so levetiracetam, benzos. It's hard to treat with medicines, and we've been seeing a lot of people use like hemp-based CBD oil, which can really, and we've seen really good results. So that's something that we want to look at moving forward. And this is the last slide, but I'll let Shafali come up and talk. But the other thing that we see is anxiety, and it's in all ages, but it really gets bad at puberty and into adulthood. And we've had people that have made themselves so anxious they've thrown up for 24 hours straight. They just, it's crazy. They can't leave the house. Some of them, we have kids that are just so, young adults that are just so attached to one parent that they won't let the parent speak. They come to clinic visits and they're hugging their parents and they're smiling, and it's kind of a typical Angelman visit. And then their parent turns to talk to me and they slap them, and then they look back at them and they smile, and they come to talk to me and they slap them. So they have this really crazy attachment anxiety. And when I know, like yesterday at the biomarkers meeting, it was mentioned that when parents say that their three biggest things are seizures, sleep, and cognition. In little kids that's the case, but in adults it's almost always anxiety and behavior. As kids get older, it becomes a huge issue, and not for everybody, but for a majority. So that tends to be the biggest thing in our adult folks that comes in. It's really behavioral stuff. So kind of overall, seizures tend to be worse when they're young and get better. Sleep can get a little bit better. GI is always there, and anxiety tends to be not so bad as kids, and then it kind of ramps up as they get older.
Is most of the anxiety around attachment issues?
A lot of it's attachment, yeah, and some of it's just, and some of it's going out. Like they get almost, I don't want to say agoraphobic, but they don't want to leave the house. The new environments, and this is stuff that didn't bother them when they were younger. It just, as they get older, it's tougher. So it's hard to know how much is environment, just kind of, if there are certain schools, or if they don't get to go out that much. But I've had kids that are, they're in these programs that just go out all the time, and they still get more anxious as they get older. I think there's something biologic to it. I'm sure there is an environmental, learned component, but there's definitely something, I think, and it kind of, again, it can go back to GABA. We talked about GABA with sleep, but GABA is also a big anxiety neurotransmitter. So I think that's kind of, along with the seizures, that's kind of wired into the syndrome. So I think that's it for me. Sorry. We can go over.
Okay, it's always tough to start the day behind, so sorry about that. I'll try to be efficient. And some of what I'm going to actually talk about, I'm going to hit on some things that I'll go into in more detail tomorrow. I'm going to talk, sorry. Okay, so I'm going to give you a quick clinical introduction to Dup15q syndrome. I have been lucky enough to work with this population for a couple of years now, and the first meeting I went to was in Sacramento, where I didn't really know much about the syndrome. I was just quite interested because of an electrophysiological biomarker that we were kind of thinking about and discovering in these kids. And over the last 2 years, I've been lucky to see up more than 30 or 40 kids now in the clinic and through other capacities. And I've just really feel lucky to be a part of this group. The families are amazing, and the kids are even more amazing. So I'm going to give you a quick clinical overview here. And actually, Stormy already gave a good genetics introduction to the syndrome. I'll just highlight a couple of things. One is that there was a Gene Reviews that was just published. Brenda Finucane took the lead on that, and a bunch of people in this room here were involved. And so that actually now provides a nice overview of the syndrome, mostly the clinical pieces of it. But just to quickly remind you that there's two main types of duplications, interstitial and isodicentric. The interstitial is basically a duplication of that 15q region within the chromosome itself. It usually leads to a trisomy of that 15q region, and then the isodicentric usually leads to a tetrasomy, or 4 copies, because there's 2 extra copies of that chromosome on a separate supernumerary chromosome. About 80% of the cases are thought to be idics, whereas 20% are thought to be interstitials, and I think 99% of those 20% are seen in Larry Reiter's clinic down in Memphis. The diagnosis, though, is usually made with microarray or FISH, and now, and we'll talk about this more tomorrow, with genetic testing being really the gold standard for any child with a neurodevelopmental disorder, microarrays and then whole exome are being done routinely on children with developmental delay. And so what's happening with that is we're seeing a larger number of children being diagnosed with genetic variants, including Dup15, often even now before the emergence of a lot of the symptoms that we'll talk about, like epilepsy or even autism. So we're seeing children diagnosed because they have a little bit of development, a little bit of motor delay in the first year of life. A microarray is being obtained and they're being diagnosed. So we are actually shifting the age of diagnosis to an earlier stage, and that actually affords us a lot of opportunities to kind of study developmental trajectories in these patients. So just to go through the clinical characteristics, so the first is that they're universally adorable. They're beautiful children, but some of the kind of facial features that we do see are a thin philtrum, down slanting palpebral fissures. They have a prominent forehead. They might have microagnathia or small jaw. And again, as I said, sometimes prominent cheeks and a forehead. This, in the Gene Reviews, I thought this was a really nice table that was put up just to sort of give a rough comparison of the interstitials and the isodicentrics, but it also kind of listed the main features that we see in these kids. And I'll go into each of these in just 1 or 2 slides of detail. The first is hypotonia, or low tone, which leads to a lot of motor delays and impairments, which we'll talk about. That's really one of the pervasive symptoms that we see through the syndrome, both in the interstitials and the isodicentrics, although milder in the children with interstitials. That, again, ties right into global developmental delay and intellectual disability, which occurs sort of at a moderate range in children with the interstitial duplications and at a more severe range for children with isodicentrics. Autism is very prevalent, reported in more than 50% of children with the interstitials, and even higher rate in children who have isodicentrics, but we more recently have been doing more directed testing towards autism in this population and find even higher rates than that. And then finally, epilepsy is very prevalent, more in the isodicentrics than in the interstitial, children with interstitial duplications, but the rate of epilepsy is about 50%. So I thought, actually, and I know we're running out of time, so I'm just going to actually do a couple of these. I thought before I go into the details of each of those clinical features, with one or 2 slides, I thought, for those of you who've never met a child with Dup15q syndrome, sometimes a little video snippet is helpful. So I'm just going to run through a few video clips. They're 30 seconds each of some children of different ages with Dup15q syndrome, and the parents have given consent to have these be shown. What I want you to pay attention to is think about kind of what are some common threads that you're seeing through these kids. And I'll just sort of of give you a clue that, one of the things to pay attention to is the motor features, some of the motor difficulties these kids have. But I also want you to sort of be alerted to the fact that there's so much heterogeneity in the way these children present and the level of kind of difficulties or disabilities that they have. So sort of think about common threads and heterogeneity. So these are two kids who are, and both of these have isodicentric duplications.
Here it is. It's loud. Yeah. Very cool. We have some toys.
Okay, so these are both children who are diagnosed fairly early. The little girl on the left that you just saw had quite severe epilepsy that was challenging to control. This boy on the right is a boy that we're going to talk more about tomorrow, actually. He's quite interesting. He was diagnosed very early at age 13 months because of motor delay. And when we first met him, he did not have seizures and had, as you see here, fairly nice skills. I'm going to show it one more time. So he's making eye contact. Again, he's sitting in a high chair. It's hard to tell the motor piece, but you'll see there's a little bit of clumsiness in how he's holding onto the toy, but a little bit more kind of better tone, if you will, in the upper extremities. Okay. So it's just this is ages 3 to 5. Again, note the fact that this little boy who's 3.5 has to sit in someone's lap to be supported, to be able to sit up. And see his head sort of sits down, so he looks sort of straight down, which can lead to sort of a perception that there's really reduced eye contact, but some of that also seems rooted in his motor challenges. And once she actually sort of pulls him up to look, he smiles and makes nice eye contact. Okay, and this is a child of the same age who had a little bit more preserved motor function.
Oh, good job, baby! Oh, now she's hungry.
Not hungry.
She's hungry. Oh.
So he's really trying to communicate. He has a lot of language, but as you can see, the articulation is a bit poor, right? He's hard to understand, and that's also largely motoric.
Yeah.
Okay, I'm not going to go through these in detail because we are definitely running out of time. I'm just going to show this kiddo.
Picture to fill in the picture. Okay, I'll have more. Let me know if you need more. Okay.
This child has an interstitial duplication.
Let me know if you need more.
So note, she's, again, doing some of these, this is one of our cognitive tasks, but note how she holds those blocks, right? There's a little bit of sort of incoordination in how she moves them. And listen to her articulation now. I just talked over her, she can't hear it.
Picture to fill in the picture. Okay, I'll have more. Let me know if you need more, okay? Let me know if you need more. Very cool. I know we can map them.
So again, note the sort of articulation issues, and we'll skip that one. Okay, so I thought that was, and I'll show a couple more videos tomorrow, but bottom line is that you can sort of get a sense of the fact that there's a range in kind of ability, but some of the common themes that we talk about, and especially in terms of motor impairment, do seem to kind of be found throughout these children. So going through the list of sort of the things that the main clinical features in terms of hypotonia. So that can actually present very early in infancy with feeding difficulties and failure to thrive. Gross motor delays can often be the first presentation, as I mentioned, and I think that's going to be a big kind of window into us being able to diagnose and see these children even earlier in development now that we're doing microarrays more often. Most children with Dup15q syndrome do achieve independent walking by age 3, but not all. And this motor function can affect all areas of functioning, as many of the clinical folks in the room know, including adaptive skills, language, and even social communication function. Okay, so what about autism? So most children with Dup15q syndrome meet criteria for autism when actual standardized testing for autism is performed. It's actually now recognized as one of the most common copy number variants associated with autism. And for those of you who may not be as familiar with the clinical side of autism, autism is a behavioral diagnosis, right, based on having impairments in social communication function and then the presence of restricted interests or repetitive behaviors. I think this quote from a paper by Battaglia a few years ago is important to sort of think about, though. He made a comment that when dealing with individuals with severe or profound intellectual disability, we should keep in mind that sometimes the cognitive impairment can lead to an overestimation of autism, in the sense that if there's global delay or cognitive challenges, sometimes when you do standardized testing for social communication, it may appear that the child has limitations in social communication when really the driving factor here is the global delay. So you might be overestimating autism in children who have profound intellectual disability. And this is actually a question that we talk about in the field a lot of autism, and it's hard to disentangle intellectual disability from autism sometimes, especially when both have kind of been there from the beginning. But I think that ultimately the bottom line is that these children meet criteria for autism. They do have social communication challenges, and so they still often need interventions and services that target social skills, even if the kind of root of it is cognitive impairment. I'll highlight a couple of sort of papers. This is from Larry Reiter's group in a cohort of children with interstitial duplications, and they basically found that all children but 2 met criteria for autism based on the Autism Diagnostic Observation Schedule. In our paper that recently was published, where we had a cohort mostly of children with isodicentric duplications, we found that all of our children actually met criteria on an autism diagnostic observation schedule, but that their autism severity was a bit lower than children with non-syndromic autism. Nevertheless, they all did meet criteria. So again, autism is very prevalent, and it's definitely something that we need to pay attention to in this population. So what about epilepsy? Well, epilepsy is also quite prevalent, more than 50%. It's definitely more common in children with isodicentric duplications. In fact, in most of our cohorts, the majority of children with epilepsy have isodicentric duplications. The average age of onset is from 6 months up to 9 years of age. It's a very common cause of infantile spasms, which is a very severe form of epilepsy that's, again, seen in early childhood and is associated with a very typical kind of EEG pattern, which we won't get into. But many children who start with infantile spasms then evolve into other types of seizures. Most of the seizure types, and there was a nice paper published a couple years ago, which I'll highlight in a minute, are multifocal, meaning the seizures are sort of occurring in different parts of the brain. Sometimes they can also be generalized, as Ron talked about in Angelman syndrome, where the seizures are really occurring across the whole scalp. What we do know is that epilepsy is certainly associated generally with more severe developmental outcomes, and it raises kind of an interesting issue, which, again, we won't get into in detail now, but which is, is the epilepsy and the developmental delay, are they both kind of phenomenon of the underlying genetic cause, or is it that in some children with the genetic cause that develop epilepsy, does the epilepsy itself actually impact further development? And that's something we're going to really only be able to unravel as we start seeing these children earlier in development. So this is quick data from a seizure survey that was published by Ron and others a couple of years ago. They looked at data from the Dup15q Alliance, and basically it was a seizure survey that was asked of patients. And what they basically found was that these children have all kinds of seizure types. There's no one type of seizure that children with Dup15q have. 50% actually had multiple seizure types, but importantly, 26% of the people who responded actually reported having a baby with infantile spasms. Okay, that's sort of the epilepsy piece. What's been really interesting is that we've been quite interested in EEG patterns, and I'm going to talk about the beta, the beta signature tomorrow in a talk. But a paper that just came out with a few of us, with the lead taken by Dimitrios Arkilo in Minnesota, examined EEG patterns in sleep in these children, and a couple of patterns emerged. Right, one was this alpha delta sleep, which really is characterized by these slow delta oscillations with kind of overriding alpha above it or through it, essentially. That was found in about a third of children with Dup15q syndrome. There was another third that also showed these bursts of high voltage, high amplitude polyspikes, and this is an example of that. And it really disrupted the sleep architecture, the classic kind of movement into increasing delta over the stages of sleep. And then another third had what we actually in neurology think of as electrical status epilepticus of sleep, meaning a pattern where there's really severely disrupted sleep architecture with what looks like essentially spike and waves in sleep. And that can be associated with developmental regression and developmental delays as well. So this was really a descriptive study, but it really highlighted the fact that in sleep, the architecture can be quite disrupted in children, particularly in children with epilepsy, but also in children who don't have seizures. And that needs to be definitely further studied, particularly from the standpoint of how this disrupted sleep architecture might affect development. We're going to hit on this excessive background beta tomorrow, so I'm actually going to skip that. The final thing that I want to actually talk about, because it's really something that's of concern and something that we discuss quite a bit in this group, and again will be, I think, the focus of quite a bit of research over time, is this concern about SUDEP, which stands for sudden unexpected death from epilepsy. So SUDEP is essentially sudden death in an individual, usually with epilepsy, in which a postmortem examination doesn't really reveal a known anatomic or toxicological cause, right? So it usually follows a seizure, but not always, but it needs to sort of be confirmed that it's not the result directly of trauma, drowning, status epilepticus, or intoxication from a medication. So it's essentially an unexpected death, likely related to epilepsy, but without a clear identified cause. SUDEP in general most often occurs in young adults, but it also can occur in individuals with quite poorly controlled epilepsy, and in that setting it can also occur in children. So Oren Davinsky, who is Oren here at the meeting? He's coming tomorrow. So Oren Davinsky has really been a leader in the field of SUDEP as a whole, and actually recently has been actually studying SUDEP in Dup15q syndrome, and this paper actually just was published by his group that actually looked at data from the patient registry, and the question was really what are the reasons for sort of mortality in Dup15q syndrome, and what role might SUDEP play in that? And I'll just again for 1 second take, and I think Oren's going to talk about this in more detail tomorrow, but the concern about SUDEP has arisen because there's been reports of SUDEP in Dup15q syndrome, and there was some concern that maybe there was an association between use of benzodiazepines and sudden death. And so that's sort of an area that has caused concern, particularly from the standpoint of whether these medications should be used in these children. And so this was partly the kind of reason for doing this more thorough investigation. So here's what the study found, and again, I think he's going to talk about this in more detail. So in the registry of 709 patients, there were 21 deaths reported, and what they did was they went back and looked at data from the registry, and then they actually went and contacted families to see if they could get more information. And so 11 families provided additional data through interview and through medical records and things. So again, limited sample in terms of the details that they had, but here's the bottom line. So they found basically that of those 21 deaths, 19 were children or individuals with isodicentric 15. The mean age was 15. 8 of 19 were female. 16 of those 19 did have a history of epilepsy. They then compared basically patients with IDIC who were living with epilepsy with those patients who had actually died, and they compared clinical characteristics. And the one difference they found, significant difference, was that the patients who had died were non-ambulatory. So they had more severe neurological dysfunction, if you will. 6 of those 19, in fact, were non-ambulatory. 3 of those 16 who had epilepsy were actually seizure-free at the time of death, meaning many of them still had very active epilepsy. So what they found was that basically 8 of those deaths of the 21, I should say, sorry, were probable or definite SUDEP, while 2 were possible. As you can imagine, it's not a very easy diagnosis to make, but that was sort of the rate that they found. Now, importantly, what they basically, the conclusion from this, though, was that the rate of SUDEP, right, in this population, and this is estimated based on the responses they received and the rate of death in the registry, that rate is actually comparable with the rate of SUDEP among patients who have epilepsy and neurological dysfunction and intellectual disability, meaning it didn't seem that the rate of SUDEP was particularly higher in this population as compared to another population with similar characteristics, okay? Which I think was an important conclusion to draw, but it really led to the more important conclusion, which is that we need more studies to really understand the mechanisms here. And an important sort of comment that the authors made in that paper was that the small sample size and the wide confidence intervals preclude any definite conclusions regarding the role of GABAergic drugs. So some of the children individuals who had died were taking medications that were GABAergic, like clobazam, but there was no way to statistically kind of analyze whether that association was significant. But they did really say they didn't observe a trend for increased mortality with the use of these medications. Okay, so I'm going to stop there, but I just want to highlight that now we have a national clinics consortium. So there's national clinics that basically, treat and evaluate children with Dup15q syndrome. Boston, Chicago, Geisinger, Los Angeles, Memphis, New York, and Minnesota are those sort of primary hubs for this. And what we have actually been doing through this clinics consortium, and a lot of this was work done by Larry Reiter and his group, is that we now have actually a centralized clinics database where we can all, as clinics, enter all of our clinical data into one common registry. And what's nice about that is that it allows us to actually obviously look at clinical characteristics, but it also then provides us a medium, and I'll put this here, right, to start actually having a dialogue about what are patterns we're seeing, what kind of assessments should we be doing in these children that we're not already routinely doing, what are clinical best practices for monitoring, treating, and managing these patients, and helping these families. And we hope that the centralized clinics database and these national clinics, which hopefully will just grow, will provide really an opportunity to do very kind of cohesive multi-site studies to better understand both the natural history and clinical care of these patients. So I'll stop there. Great question. So the question was whether there's differences by sex, right? So girls and boys. And we have analyzed this in all of our developmental and behavioral data, and the answer is no, from the standpoint of epilepsy, cognition, autism. The place that we do see some differences by sex is in some of the comorbidities, particularly anxiety. So anxiety tends to be more common in girls, which is actually pretty consistent with kind of the broader literature on anxiety. So it's quite interesting. Some of the mood disorders that emerge a bit later in childhood are more common in girls. That has not actually been studied well, so that's through our smaller database, but it's definitely a great question. Yeah.
Have the SUDEPs and Dup15 and IDA15 ever been compared to the Angelman one?
So the question was whether the SUDEP cases have been compared to those in Angelman. I'm going to say no, based on the literature. Oren may be a better person to answer that question in terms of whether there's a plan to do that. It's a great question. I mean, I think in general, it's such a rare phenomenon that there is a need to sort of study SUDEP across, different syndromes where there might be a heightened risk. Because really our goal is to be able to provide, helpful prognostic information, and also for us to be able to, track children who might be at higher risk and do everything we can to prevent that, right? So that's really the question.